Hello everyone. Welcome back to SurgicalUtopia. As we all know that in the second wave of pandemic COVID-19, we are all facing with many challenges such appearance of new diseases. Such disease which has lately become very popular as black fungus. In today's video we will discuss about the recent management of black fungus. Black fungus, also known as mucormycosis, is a life-threatening infection caused by fungi of the order Mucorales. Recent reclassification has abolished the order Zygomycetes and placed the order Mucorales in the subphylum Mucomycotina. Mucormycosis typically occurs in patients with diabetes mellitus, patients who have received organ or hematopoietic stem cell transplant, HSCT, patients with neutropenia, or patients with malignancy, that is, patients with compromised immunity, which is also the case in the patients with post-COVID recovery. Now let's know why mucormycosis is affecting patients with COVID history. Height. Get ideal environmental conditions. In COVID patients such as low oxygen or hypoxia, high glucose levels due to diabetes, high ferritin levels, decreased ability of WBC to phagocytose, prolonged hospital stays, with or without ventilation, low pH value. Now let's see what is the clinical features mucormycosis. Fever, running nose, crusting in the nose, loss of sense of smell, pain in malar region, ulcer in palate, area of ischemia on face. As we know, early detection and early treatment can save the life of patients and reduce the mortality rate. So here are few alarming signs for early detection of the black fungus. Pain in the orbital region. Second sign is reduced visual acuity. Thirdly, affected colored vision. Next, you may detect it if the patient complains of double vision or diplopia. Neck rigidity, seizures, vomiting are other signs of black fungus. We have Dr. Marcus to discuss the management of black fungus. Welcome, Dr. Marcus. Kindly tell our viewer about the management of the very famous black fungus disease.
Thank you for having me here for this discussion. As far as management of black fungus is concerned, amphotericin B deoxycholate remains the only licensed antifungal agent for the treatment of mucormycosis. Lipid formulations of amphotericin B are significantly less nephrotoxic and can be safely administered at higher doses for a longer period of time than amphotericin B. Treatment with liposomal amphotericin B was associated with a 67% survival rate. The response of mucormycosis to antifungal agents is host and site dependent, and is particularly problematic in patients with hematological disorders and HSCT recipients. Fluconazole and voriconazole do not have reliable activity against the agents of mucormycosis, and the activity of itraconazole is primarily limited to Absidia species. In contrast, posaconazole has enhanced in vitro activity against the mucorales. But pharmacokinetic and pharmacodynamic data raise concerns about the reliability of achieving adequate in vivo levels of oral posaconazole to treat mucormycosis, in contrast to aspergillosis. The successful treatment of mucormycosis requires 4 steps. 1. Early diagnosis. 2. Reversal of underlying predisposing risk factors, if possible. 3. Surgical debridement where applicable. And 4. Prompt antifungal therapy. Early diagnosis of mucormycosis. Initiation of pollenotherapy within 5 days after diagnosis of mucormycosis. Reversal of underlying disease. It is critical to reverse or prevent underlying defects in host defense when treating patients with mucormycosis. Immunosuppressive medications, particularly corticosteroids, should be administered at reduced dosages or stopped if at all possible. Aggressive treatment to rapidly restore euglycemia and normal acid-base status is critical in diabetics and ketoacidosis. Primary antifungal therapy. Primary antifungal therapy for mucormycosis should be based on a pollen in most cases. The optimal dosages for treatment of mucormycosis are not known for any antifungal agent. Starting dosages of 1 mg per kilogram per day for amphotericin B and 5 to 7.5 mg per kilogram per day for liposomal amphotericin B, or commonly used for adults and children. Whether higher dosages provide any additional benefit is uncertain. However, increasing the dosage of liposomal amphotericin B to 10 mg per kilogram per day for central nervous system mucormycosis may be considered, on the basis of the limited pollen penetration into the brain. Salvage therapy. Defuroserox or posaconazole were reasonable salvage options for patients with mucormycosis refractory to or intolerant of pollen therapy. If defuroserox is used, it should be administered for 2 to 4 weeks during salvage therapy, because in preclinical studies of non-iron overloaded primates, defuroserox toxicity increased beyond 4 weeks of therapy. In contrast, posaconazole appears to be quite safe, despite dosing for months to years. For patients with mucormycosis, who are receiving immunosuppressive medications, secondary antifungal prophylaxis is typically continued for as long as the immunosuppressive regimen is continued. Posaconazole may be an option if pollens cannot be used for prolonged periods. For patients with intermittent immunosuppression, such as those receiving intermittent cycles of chemotherapy, who have adequate leukocyte counts between cycles, secondary prophylaxis should be reinitiated during neutropenia and should continue until the recovery from neutropenia. So that's all for the medical management of black fungus. The surgical management is multidisciplinary, which includes a team of ENT surgeon, maxillofacial surgeons, optical plastic surgeons, neurosurgeons and anesthesiologists.
With this we come to end of today's video. We hope that this informative for you. We at SurgicalUtopia advise you to take your vaccine as soon as possible. We wish you a healthy life. Stay home and stay safe. Until we meet in another video. Thank you and bye-bye.